Welcome back to day two of the Cell and Gene Therapy 2023. I'm George Hammond, conference producer at Technology Networks, and I'm here to introduce our first talk of the day, Suppressing Neuroinflammation, Precision Medicine, Cell-Based Therapy. I'm pleased to welcome Dr. Stanley Appel as your presenter. Dr. Appel is former chair of the Stanley H. Appel Department of Neurology at Houston Methodist Hospital, Texas, and currently serves as chair of the Scientific Advisory Board for Coya Therapeutics, Inc. An internationally renowned researcher and neurologist, Dr. Appel is dedicated to the treatment of patients with ALS and is one of the nation's foremost experts on the disease. He has spent more than 40 years devoted to understanding the human brain and has written 15 books and more than 450 peer-reviewed articles. A warm welcome to you, Stanley. Following the presentation, we will have a Q&A session, and we welcome any questions that you may have. Please ask questions using the Q&A system to the right-hand side of the video player. You can also use this feature to connect with attendees and discuss a talk. So feel free to take advantage of the chat system by introducing yourself and sharing your thoughts during Stanley's presentation. If you experience any technical difficulties during the presentation, please request help using the technical help icon in the menu on the left-hand side of the player. And now, without further ado, I will hand over to Dr. Appel to begin his presentation.
Thank you very much, George. We appreciate the opportunity to present our thinking and our progress we've made in cell therapy as it applies to neurodegenerative diseases and more specifically ALS. So here are my disclosures. I think the most critical one is that I'm chair of the Scientific Advisory Board for Coya Therapeutics, and Coya Therapeutics has licensed all of our technology know-how for cell therapy for neurodegenerative diseases from Houston Methodist. So let me start with a very simple diagram to describe how ALS affects the body. We move by virtue of two neurons, simply put, an upper motor neuron in red here that goes from the brain to the back of the brain and all the way down the spinal cord, and it connects to a lower motor neuron, lower just not meaning legs, but arms, tongue, legs as well. When in fact the red is compromised, then we end up with spasticity, hyperreflexia, stiffness, and a loss of balance and gait. If only the red is compromised with motor neuron disease, we call that primary lateral sclerosis. When the green is compromised, it results in weakness, wasting of muscles, and jumping of the muscles, so-called fasciculations. And when only the green is compromised, we call that progressive muscular atrophy. So to make a diagnosis of ALS, you need compromise of both upper, the red, and lower, the green motor neurons, and that results in the diagnosis of ALS. Now, there are a number of different criteria that have evolved over time that go by fancy names depending on where the meeting was held to reach consensus. But the most recent consensus simplifies our diagnostic abilities and is called the Gold Coast criteria because of its being the result of a meeting on the Gold Coast of Australia. So progressive motor neuron impairment, repeated clinical assessment, then you add both upper and lower motor neuron dysfunction in greater than one body region, or lower motor neuron dysfunction in greater than two body regions. So that if we have only the green involved on this previous slide here, but it's in two or greater body regions, this still qualifies for the diagnosis of ALS by these new Gold Coast criteria. If there's only one body region, but affecting upper and lower motor neuron in both areas, then this also qualifies. We need to exclude a number of other possible diagnoses that are mimics of ALS, and we do that based on MRI, by electrical studies, so-called EMG and nerve conduction, as well as biofluid analyses of blood or CSF. So having made the diagnosis of ALS, now the question is, what are the criteria and characteristics we can talk about with respect to it? There are two relatively very famous people that, in fact, we recognize as having had ALS. One in the States, Lou Gehrig, who had his disease diagnosed in the late 30s and went very rapidly over a period of just 2 to 3 years. And the other, of course, is Stephen Hawking, who went 55 years living with ALS and given the opportunity to conduct his brilliant experiments as thought experiments. So most common adult motor neuron disease affecting 30,000 patients in the US, 6 to 7,000 new cases a year. Male predominance overall 1.5 to 1, but in the 20s, it's almost 4 to 5 cases to 1, male to females. But over the age of 60, as you get older, it becomes 1 to 1 male to females. Increasing age, increased incidence. The number one risk factor for ALS, as the number one risk factor for Parkinson's and Alzheimer's, FTD as well, is in fact age. Now, 90 to 95% of the cases, there is no specific history you can take from the families, but in 5 to 10% of the cases, you get a positive history in several generations. The most common of these is so-called C9orf72, which accounts for almost half the familial cases. That is, if it's 50% of the 10%, then it's overall 5% of all cases. And mutant SOD is a mutation that accounts for 20 to 25% of the familial cases. This latter one is extremely important because of the elegant studies that we'll discuss later, in which we have alterations in mutant SOD that appear to be corrected by antisense oligonucleotides with a slowing of progression in the patient's deterioration, resulting in FDA approval of this antisense oligonucleotide just this last week. We used to say that in ALS, the brain is not really involved with any cognitive dysfunction, and we found that's really not the case. In 50% of the cases, there is executive dysfunction, that is a slowing in problem solving and leadership characteristics that we see, usually mild to moderate. But if it's very severe, then we know the frontal lobe is compromised with frontotemporal dementia in about 15% of the cases. And it usually manifests itself either as behavioral variants or primary progressive aphasia and language dysfunction. And these are the characteristics of FTD in 15% of the cases. Now let's look at the genetics, because we've made great progress in understanding the genetics of ALS, and it's developed for us an understanding of the pathways that are compromised. So here's C9orf, the most common of the familial cases. Here's mutant SOD, discovered in the early 90s. C9orf was first described in 2011, and a variety of other mutations that are linked directly to ALS. Let's look at the motor neuron, and we see there's a wide range of different structures compromised by different mutations. So axonal dysfunction is seen with a number of these mutations. Alterations in the disposal of the cell, autophagy in the proteasome, accounts for another number. TDP43 is present as an increased alteration in a large percentage, maybe 95% of the cases, but a smaller number of patients may have a specific mutation, and that results in alterations of RNA and specific splicing. Misfolded proteins, SOD1, TDP43, can give rise to dysfunction. And I just want to point out a group of mutations that are characterized by involvement of the glia, the microglia, the astrocytes, and these are the evidence and the confirmation that if you alter glia in some significant way such that they become pro-inflammatory, then you end up linked to ALS as well. It's really interesting that in European families, C9orf is one of the major mutations, whereas in Asian families, C9orf is only a very small percent of the cases, 40%, and it's led by SOD1 superoxide dismutase 1. So let's look more specifically at the mutation. Superoxide dismutase, first described in 93, now recognized in 20 to 25% of familial cases and over 140 mutations. It's important to note that it is not the enzyme activity being increased or decreased that's responsible for the mechanism of action. It's the protein that results in aggregates that gives rise to a toxic gain of function, not the loss of enzyme activity. For C9orf, 40% to 50% of the ALS cases, but it's interesting that 5 to 10% of cases where there's no family history in most of our populations still may have evidence of C9orf72 mutations. 3 major reasons as the mechanism of action: reduced mRNA levels of the gene involved in C9orf, RNA foci with RNA altered splicing, sequestration of RNA binding proteins, and most critically, dipeptide protein toxicity that alters cellular metabolism as well. Now, here's the data that resulted in the FDA in the United States passing the antisense oligonucleotide as therapy for the mutant SOD1 bearing disease. The compound, the antisense, is called tofersen. And what the patients did is they were subjected either to a placebo group, which is in blue, or to the tofersen. And here is the clinical score that we use to judge burden of disease and rate of progression. And you can see there's a slight difference. The placebo compared to the experimental antisense oligonucleotide, but this was barely significant. So what was done, which was really important, was that all patients, whether they had been previously on placebo or on the experimental antisense oligonucleotide, were continued on this medication. And now you see there was a leveling off, and those patients who were on the experimental drug for a year compared to those that were only on for 6 months. So it was the fact that there's a delay in time before you really begin to see a beneficial effect when you're shutting off the gene that is making the mutant SOD in patients. Now, in addition, the same thing was seen with regard to the breathing parameters, with the time to death, and with the strength, the handheld dynamometry. So if we can look at this, tofersen in the first 6 months reduced the total CSF SOD1, but it wasn't enough to cause a major difference, but at least it indicated target engagement. Here's the key issue that the FDA used, a biomarker. Biomarkers are becoming extremely important as ways to document that we are affecting both target engagement and we may be reducing axonal injury and neurodegeneration. And then it continued with suggestion of slowing decline and faster progressing disease as we went from 6 months up to a year, and it reduced the decline in clinical function, respiratory function, and as a result of this, the FDA approved this drug, a major milestone for the therapy of ALS with its significant unmet need. So in general, we can think about ALS as starting at the neuromuscular junction, a dying back phenomena with retraction of the nerve terminal, alterations in oxidative stress, autophagy, and neuroinflammation. Now, there are those who believe that things do not start at the neuromuscular junction. They may start in the motor cortex. In our hands, in our studies, it looks like at least 2/3 to 3/4 of the patients represent this dying back of the motor neuron from outside the blood-brain barrier, whereas maybe only 10 to 15% start at the motor cortex and the rest are mixed. But this is a process of a retrograde dying back phenomena. Now, what is clear is that the neurons do not die alone. Now, if you go clinically, you see that different mutant genes give rise to the same clinical phenotype, and different clinical phenotypes may result from the same mutant gene. So this is extremely important, and what it tells us is that other parameters are critically important, and our focus in our group in cell therapy has been on neuroinflammation as characterized by altered macrophages, microglia, astrocytes, and T cells. So neuroinflammation as a major means of propagating neuronal injury in neurodegenerative diseases. So what are the characteristics of neuroinflammation? Well, there's serum pro-inflammatory cytokines being elevated. There's increased pro-inflammatory gene expression in macrophages. There increased oxidative stress and lipid peroxides, and in fact, increased acute phase proteins. Here's a problem that this represents. If we have a monoclonal antibody to IL-6 and we suppress the IL-6, those studies did not indicate a major benefit. And the reason is very simply that there are so many other pro-inflammatory cytokines as well as oxidized LDL lipid peroxides. So this is the rationale for where cell therapy is critically important, because the cells that are neuroprotective can in fact suppress multiple pro-inflammatory cytokines at the same time, as well as oxidative stress. So what's the evidence that neuroinflammation contributes? Is it just correlations? And mutant genes, as I mentioned, linked to ALS provide compelling evidence for the involvement. More specifically, a number, optineuron, TBK1, etc., including the C9orf and the SOD1, alter the innate immune system. And I've listed a whole series of these genes and the way in which they could alter the cells and give rise to a pro-inflammatory status and enhanced pathways. So here are the major components of the inflammation with immune alterations. The blood macrophages and CNS microglia are increased pro-inflammatory states. The neurotoxic Th1 lymphocytes are pro-inflammatory. And most critically, the neuroprotective regulatory T lymphocytes are decreased and dysfunctional. So we looked at monocytes and we did an unbiased approach on the monocytes and documented that pro-inflammatory gene expression is significantly elevated in ALS compared to controls. And here you see the results of that study. And if we look at interleukin-1 beta in normal controls compared to ALS, ALS is significantly elevated, increased gene expression of interleukin-1 beta in monocytes. If we look at the anti-inflammatory characteristics of monocytes, we find that in ALS, genes such as the expression of CD206 are downregulated compared to controls. And then if we look at the ratios, you can see the ratios of the bad guys to the good guys far more elevated in ALS. So what's going on is you have a variety of pro-inflammatory cytokines, markers of oxidative stress in macrophages and microglia that are self-propagating and enhancing this process. Increased pro-inflammatory cytokines cause increased oxidative stress and lipid peroxide, and increased oxidative stress, oxidized LDL, cause increased pro-inflammatory cytokine. Well, let's look at the motor neuron in some detail. And here you see the concept that neuroinflammation is not limited to the CNS in ALS, nor is it limited in Alzheimer's, frontotemporal dementia, or Parkinson's as well. Yes, there are processes ongoing of programmed cell death within the CNS, of apoptosis, where the cell will die, of necroptosis, which increases inflammatory processes, and ferroptosis. And I just want to focus for a moment on ferroptosis, because ferroptosis is the programmed cell death in which mitochondria are altered, in which you've got a production of lipid peroxides, iron is increased, and the protective glutathione is decreased. And this is going on systemically in patients with ALS, such that the peripheral compartment is contributed in a significant way, which is why the disease moves so quickly and compromises many constituents. Liver acute phase proteins are increased. These liver acute phase proteins are not made in the CNS, they're made in the liver, and whether it's you're dealing with soluble CD14, whether we're dealing with lipopolysaccharide binding protein, or whether we're dealing with CRP, all of these are heightened production by the liver, and they are reflecting a pro-inflammatory status peripherally. So just wanted to show you, this is from a study we did a number of years ago, where the mitochondria are altered in different ALS patients, increased calcium, swelling of that. So there is definitely iron dyshomeostasis. Look at a neuropathy with denervation, no increase in calcium, no marked disturbance of the mitochondria. So this compares really unfavorably with what is going on in ALS. So you have a parasite, a glia, that peripheral, that is surrounding Schwann cell envelopment for regrowing of the motor nerve terminal, and you don't see the Schwann cells surrounding ALS. So that's involved in the failure to reconstitute the neuromuscular junction. Ferroptosis, and you're going to hear more of that as we go forward with respect to therapy. So the mitochondria, if there's a limited amount of calcium, you end up with entry production of ATP. But if you have a dramatic increase in calcium, then you have an increased apoptosis, ferroptosis, increased oxidative stress. So the increased calcium results in increased arachidonic acid, lipid peroxides are formed, and you end up with increased serum and CSF 4-hydroxynonenal, the lipid peroxides in sporadic ALS, even more than in familial compared to normal controls and neurodegenerative diseases. Early ALS has increased in 4-H&E compared to controls, but as you go mid and late, it increases more. So, biomarkers. The lipid peroxide and oxidative stress are biomarkers, and the potential role is resolving the complexity. As I mentioned, in the antisense oligonucleotide, it was clear that the FDA recognized neurofilament, but neurofilament isn't the only biomarker that may be important in cell therapy. Lipid peroxides and oxidative stress may represent opportunities. So now on to our T cells. Treg cells have a suppressive effect on other T cells, and naive T cells can be made into Tregs in the presence of TGF-beta, but when interleukin-6 is present as well, then you end up with Th17, and the Th17 can produce pro-inflammatory cytokines. So here's a simple diagram of what's going on. Regulatory T cells suppress Th1, but under circumstances where the macrophages become activated, you end up with dysfunctional Tregs, an increased cytokines and oxidative stress, and bad guys in T cells as well as activated macrophages. The dysfunction is present with regard to burden of disease and also with regard to rate of dysfunction. The faster the rate of progression, the less suppression. Now, so in fact, if we look at healthy Tregs can suppress, the M1s can convert the healthy Tregs into dysfunctional Tregs, but how are we going to deal with this as a clinical therapy? And we found that when you expand the Tregs outside the body, they turn healthy and they are able to suppress Th1s, Th17s, and M1s. And we use this as the basis of our therapy. So we take the dysfunctional Tregs in a GMP facility, and we expand the Tregs, and then we take these same Tregs where the dysfunctional Tregs had come from the same patients, and we use these for autologous infusions into the patient, which then is suppressive. And this was the basis of our first study. In addition, we've now learned that with Coya Therapeutics, that we can use biologics to increase the in vivo production of increased Tregs and making them more suppressive. But I'm going to focus on the two studies that we carried out here in cell therapy. So here are 3 patients that we did, one patient going very quickly, one patient going at an intermediate rate, and this nurse going relatively slowly. We took their Tregs out, we expanded them in a GMP facility, and we gave them back to the patient. And what we found in each of the patients, this is 2 different ways of assessing clinical status. the ALS-FRS, which is used uniformly throughout the world, and our own ALS, which in certain respects is a little more sensitive. So the lower one is the ALS, and this one, upper one, is the ALS-FRS. So every 2 weeks for a total of 4 infusions, we suppressed the inflammation. But when we stopped, the patients fell off the mountain. And here you see we're able to stop it with monthly injections. And this seemed to appear to have stopped, but we did stop by virtue of our ALS as well. So this was patient number 1. Here's patient number 2. Once again, we stopped, and here it became clearer. We dropped in between, but we stopped progression when we gave monthly. So this was a very promising result. Here's patient 3 that was going slowly, and we really felt very comfortable that in all 3 patients, we had a promising result. When we looked at the Treg suppressive function, during the first 8-week period, we had an enhancement in suppression. It was lower after we lost some time in between when the patients were not on this, but we in fact were able to stop progression in all 3 again. And here was the correlation that with clinical state, the patient appeared to do better, and the suppressive function was correlating with the clinical state. Now, here's what was happening in lipid peroxides. With ALS patients, overall, there's an increased lipid peroxide. This is oxidized LDL. And when we separate the patients into fast progressing and slow progressing, we end up with a dramatic increase in fast. And this is true whether we're talking about oxidized LDL or 4-hydroxynonenal. And this is important because look at this is the score clinically. Here the patient had suppression of oxidized LDL. When we stopped, there was an increase both in oxidized LDL and 4-H&E. And when we started again, there was a suppression, but then we lost the ability to suppress. Subject 2 did the same thing with respect to what was going on with 4-H&E, and the evidence is really quite compelling on oxidized LDL. And subject 3, even though the patient was doing reasonably well and dropped just a little bit, here when we stopped, we had an increase in oxidative stress. So autologous infusions in this first study of ex vivo expanded Tregs were safe and well tolerated, and critically, markers of oxidative stress were suppressed during infusion despite continued subcutaneous IL-2. And in our hands in these patients, neurofilament light levels didn't change. So autologous infusions of expanded Tregs can suppress systemic oxidative stress. Well, let's go on to our second study, which we just finished last year, and unfortunately, COVID-19 prevented a really complete analysis of Tregs versus placebo in the first 6 months of the study. But we were able to continue on with 3 subjects on the Tregs, 3 on placebo. Then we were able to add 2 patients just on the placebo, as well as on the Tregs. 2 subjects enrolled into an open label extension. So here are the results of that phase 2. The first 6 months, because of COVID-19, too few patients to analyze, but in 6 of the 8 patients, we did have evidence of promising results, while 2 of the 8 were completely unresponsive. So what is important is we found that the lipid peroxides in the unresponsive patients were significantly elevated, And if the lipid peroxides are too high, then even cell therapies such as Tregs by themselves are not sufficient. Now, whether in fact the infusions can truly slow disease in ALS needs to be determined by a large double-blind placebo-controlled clinical trial. And this, of course, is where we're going in the future. Just to show you some of the data, here's the Treg in the open label extension. Suppressive function went up. The Treg numbers went up. Here are the two patients that didn't respond at all, despite giving them the Treg therapy. But in the patients that did respond, 6 of the 8, which to us is a very promising result, there was minimal change over this period of time, which is truly unusual in ALS studies. Now, here is the evidence of open label extension, where the 6 participants down here had very little in the way of interleukin 17, interleukin 17F and C, and the oxidative stress was decreased, and the 2 patients had significant increase in oxidative stress. And if we look at specific markers for H&E, here are the 2 patients over the entire course while they're receiving the Treg therapy together with IL-2. Here you see that despite that increase for H&E in both these patients, whereas in the other patients, the 6 of the 8, they did extremely well. And these 2 patients who were only in the open label for 6 months, when we stopped, the oxidative stress started coming back, and they did well too. And also, if we look at the CCL2, which is a pro-inflammatory cytokine, used to be called MCP1, they also were significantly elevated in the 2 patients who did not respond, whereas the 6 patients who did respond did extremely well. So we have lessons from our cell therapy. Oxidative stress biomarkers with enhanced calcium and mitochondrial alterations are present, and one of the major areas that is producing these is messages of ferroptosis from the motor neuron axon terminal, an early change. The oxidative stress activates the macrophages to a pro-inflammatory phenotype, and contribute to Treg dysfunction. Any oxidized LDL are decreased by Treg immunotherapy. However, if the oxidative stress is suppression may not be effective, and these are effective biomarkers. And Coya Therapeutics and our group at Methodist are working together with combination therapies now of suppressing oxidative stress and lipid peroxide and enhancing Tregs. So we feel that 1 + 1 may equal 3, not just 2. And this, we feel, is our target, therapeutic target, going forward for cell therapy. Well, I've covered a great amount of territory. I thank you for listening and would be happy to listen and help with any questions you might have.
Thank you so much, Dr. Appel. That was a fantastic presentation and a great way to kick off the second day of the event. As with all the other talks today, we're likely going to have lots of questions from the audience, and I can see that we have received some already, so I'll move straight onto these now. So your first question is, what role do you see cell and gene therapies playing in the future of ALS treatment, and how do they compare to existing treatments in terms of safety and efficacy?
Well, I thank you for that great question. And the reason I'm thanking you is I hesitated, neglected to mention that our trials were completely safe. There was no evidence of any toxicity, which was very gratifying. Furthermore, none of the patients dropped out. The COVID-19 precluded patients coming to the hospital to be assessed. That's why the first 6 months we couldn't use the data. So safety, well tolerated. Now, if we look at all the data, the lesson we've learned is you need to suppress inflammation, not just with Tregs, but there are various ways we now at Koya have cell biologics that can suppress neuroinflammation and prevent dysfunction of Tregs. And we're very excited that that combination appears even more promising than taking the cells out and expanding the GMP. But combinations of therapies may be a way to go in the future. Combinations of cell therapies, we think, are the wave of the future.
Thank you, Stanley. That is fantastic. And your next question follows on from that quite nicely, which is, how do you envision these therapies being administered to patients, and what are some of the potential challenges in their delivery and accessibility?
I think that also is a great question. So our therapies that I've discussed in the 2 cell trials that we did were taking the cells out of the patient, expanding them ex vivo, and then administering them intravenously back into the patient. Everyone asks us, do the Tregs that you've taken out and expanded that have become super suppressive, do they get into the CNS? As I've tried to explain with the diagrams, they don't need to get into the CNS. The neuromuscular junction is outside the blood-brain barrier. So that means that therapies that we can use can be administered either subcutaneously or intravenously, and they will be similarly effective. And our study that we're just finishing up now of the dual therapy is in fact administered subcutaneously with the 2 hit phenomena, suppressing neuroinflammation and enhancing Treg suppressive function. As long as the target is a systemic target, we know how to reach these areas, spleen, lymph nodes, etc.
Thank you, Stanley. Another excellent answer. Moving on, we've still got some time for some more questions for this session. So your next question is, based on your positive results with cell therapy in your previous research and clinical trials, what challenges have you encountered in developing and administering this therapy?
Well, once again, that's a great question. Let me talk about the second study that we did, because it brought up an interesting point. As I showed you with regard to regulatory T cells, the neuroprotective T cell that was first developed, and we learned so much from Shimon Sakaguchi, who discovered T regulatory cells in FOXP3. These cells, in the presence of TGF-beta, can be developed. But the minute you've got a high amount of interleukin-6, then the Tregs, which are not end-stage differentiated, can become Th17. And in the second study, we had evidence for that, because we in fact had increases in IL-17. IL-17 is produced from Th17 cells. And so what we found is that you've got to make sure that you suppress the inflammation. Otherwise, the Tregs can turn into Th17. And that looks like the best explanation for why our 2 patients that didn't do well, didn't respond, in fact had increased markers of Th17, which got us into trouble. So we need to suppress the inflammation, which is what we're targeting at Koya Therapeutics now, in addition to enhancing Treg suppressive function. so that we have a synergistic therapeutic effect.
Thank you for that. That's fantastic and incredibly well explained. We've got time for just a few more questions today. Your next question is, what is the timeline for the development and clinical testing of these therapies, and what steps are needed to bring them to the market?
Well, right now we're focusing on the dual therapy at Coya Therapeutics, and as in any other study, considerable resources are required because you can't go with a small number of patients, such as 4, 8, 10. You need to do at least 40 to 50 to 60 and do a double-blind placebo-controlled trial. And our goal is to get this into patients no later than the last quarter of 2023, and hopefully, if not then, in the first quarter of 2024. We're optimistic that we can do this and excited for the opportunity to help our ALS patients.
That is fantastic. And what better reason to be able to help someone? So your final question for today, Stanley, is how do you see cell therapy fitting into the overall landscape of ALS treatment options? And do you think it has the potential to become a widely used therapy in the future?
Well, I think I touched on that a little bit in my presentation, but let me just make the point and amplify on it. We know that oxidative stress, we know that pro-inflammatory cytokines are driving inflammation in the pathophysiology of ALS. But we also know that cells are the best way to suppress a large number of pro-inflammatory cytokines and a large number of altered oxidative stress markers. So from my perspective and our perspective at Coya, there's no question that cell therapy represents the best way to go. Now, there's no question also that as we learn more and more how to suppress various parameters collectively, we obviously will be looking at oral therapies that can substitute for cell therapy. But we're now in the area of cell therapy, and right now it looks like the lowest hanging fruit that will help us meet the unmet need in neurodegenerative diseases.
Thank you so much, Stanley. Unfortunately, that is all that we have time for today, but it's been an absolute pleasure, and you are definitely an expert in your field. Any questions that we didn't have time to get to will be sent to the speaker following the event. And that just leaves me to say, as with all the other talks in the event, this talk will now be available to view whenever you want for the next 30 days. I just want to say thank you once again, Stanley, and we will be back soon with the next talk.
All right. My pleasure. Thank you for the honor and privilege.